2022 daily recap. I'm joined by Room Now faculty, good friends, Kathryn Dao and Eric Dein. Folks, how are you? Eric, take off your mic. I'm in Copenhagen, and Kathryn, you're in Dallas, and Eric, you're in, where are you?
I'm in New Jersey.
New Jersey. Okay, so this is a hybrid meeting, and that seemed to be a lot of the discussion here at the meeting. That one, we're back. Big meetings, big crowds, long lines for the bathroom. No one can find anything but those little cups of coffee, and but people were thrilled. But it is a hybrid meeting, and people are still digesting what that means. From your end, Kathryn, Eric, what's it like? You're doing this at dark 30, aren't you?
Well, actually, today wasn't that bad because I got up at 5. And then when I was looking at some of the tweets that were going on, I'm seeing long lines and I'm like, oh Lord, I'm not going to wait in that line. And especially for the bathroom, sorry. And then somebody was complaining they can't find coffee anywhere. So I'm actually glad I'm
Coffee's everywhere. There was no food, but coffee was everywhere. Even I think the garbage men were selling coffee. It was just amazing how much. I don't know who that person was. That person was probably in New Jersey. Eric, did you have coffee this morning?
I definitely had a couple cups this morning, but and I will have a few more when we start at 4 a.m. tomorrow. But yeah, there's definitely FOMO being here across the computer screen, but we've gotten good at doing virtual meetings, so it's definitely easy to bounce between sessions and see what you want. And there's definitely advantages to virtual, but it's hard to look at the pictures of everyone smiling together and not miss it a little bit to be back in person.
So in case people don't know what FOMO is, it's fear of missing out.
Thank you.
Yeah. One of the unusual things about this meeting is that if you're registered as a live attendee, you don't have access to the virtual feed. Mm-hmm. If you are registered as a virtual person, obviously you're not going to be there live. So there is still some issues with how we're consuming the meeting. Kathryn?
Sorry, I didn't realize you were addressing me. You dropped out for a moment there. So
okay,
what I
so
thought
why don't
was,
you begin?
Yeah.
We're going to begin and discuss our key abstracts that we thought were important from today. We're going to present 2 each. So why don't, Kathryn, you start. Eric, you go second.
Well, I just thought that it was kind of controversial in the very beginning how, they were talking about advances in rheumatology at the opening plenary session. And they said that Danish law mandated that rheumatologists see patients within 4 weeks of referral. And I'm just thinking to myself, all of us in America, we're probably going to go to jail.
NICE has a similar sort of recommendation.
Yeah, I mean, I would love it if we could see patients within 4 weeks, and maybe that's what we should strive for. But I thought what was really exciting was actually the EULAR 2022 ANCA-associated vasculitis recommendations. There were several new recommendations as well as some revised ones. So some of the new recommendations include like treating with rituximab. They would prefer that, or cyclophosphamide. And then also like for maintenance therapy, they would recommend methotrexate, mycophenolate, or rituximab. But one of the things that also was a little bit controversial with the ANCA-associated vasculitis recommendations was PJP prophylaxis, because that really got a lot of hits on Twitter, because the recommendations were to continue PJP prophylaxis for 6 months. If the B cells are repleted, then you can stop. And then also if prednisone is over 20 milligrams a day, then you should go ahead and continue it. So where there was a lot of heat on Twitter was the fact that you have to wait for the B cells to be repleted before you can stop PJP prophylaxis. So there's really not a lot of data. Some of these are recommendations with high agreement, but not a lot of data. So I don't know what you all do in that kind of circumstance.
Yeah, I found that interesting.
Go ahead, Eric.
I found that interesting because that's different than I really always focus on prednisone dose and whether prednisone's over 20 milligrams and less on the rituximab in the absence of steroids. And again, this is kind of as we get outside of what we have evidence base for. But I did a poll on my Twitter to see if people agreed with that. And in patients on rituximab without high dose steroids, 52% said no, they would not use prophylaxis, and 48 said yes. So it's kind of been bouncing back and forth around the 50% mark. So it's definitely interesting that they felt that they could make a recommendation where it does seem to be a bit divided.
Well, I think heretofore the use of prophylaxis might have made sense in vasculitis, where it's vasculitis, they're sick, they're getting mega doses of steroids, they're on Cytoxan. That used to be the risk factor. The new risk factors for PJP is Rituxan. There is a contribution of vasculitis and of steroids, but if you do any research on who gets PJP these days, Rituxan is like the dominant issue. And so I'm glad to see those recommendations. I think they make sense.
And Carol Langford, if you remember, she just says that, patients with GPA, they're just really high risk for a PJP pneumonia, period. So she would recommend prophylaxing them with trimethoprim sulfamethoxazole for everybody, kind of like regardless of what they're on.
Eric, what do you have from today?
So I was going to continue with the EULAR recommendations. I thought the other great part of that was the update on the RA guideline. So that was last updated in 2019. And so over the past 3 years, it's interesting to see how these guidelines always kind of give you the window to what the conversation has been in the last couple of years. And so the two main questions that they wanted to address with it were, number one, glucocorticoids with initiation of DMARDs or change of DMARDs. And number two is, of course, the issue with the JAK inhibitors and the oral surveillance data, incorporating that into the guidelines. So with the steroids, they were really responding to the fact that since their last guidelines, there were the 2021 ACR guidelines, that was a change from EULAR had recommended to consider the use of glucocorticoids with initiation of DMARDs, whereas ACR in 2021 recommended against using steroids, with the reason being, of course, the long-term toxicity and how difficult it can sometimes be to get patients off of it. So the question was for EULAR if they wanted to go ahead and agree with ACR or have somewhat of a contrasting view. And they came down a little bit more in the middle, but they still recommend a consideration of use of glucocorticoids. But they added some stronger language to say that they recommend tapering and discontinuing steroids as soon as possible. So they just kind of beefed up that language a little bit. But that is a little bit different from ACR, which really would prefer that patients are not on steroids on the outset. And then the second.
So before you go on, let me just say that Dr. Smolin, in a 20-minute presentation, spent 10 minutes giving the explanation for what they just said about steroids and endorsing steroid use. And you're right. The ACR guidelines are all about methotrexate for everything and all about don't use steroids if you can get away with not using steroids, like repeated warnings about not using steroids. And the EULAR is exactly different. And I think it reflects the differences in the cultures. Martin Boer's known for Cobra and high dose steroids, and he's got a following in Europe that says that that's okay. And not so much of a big following here in the United States. So it's a cultural issue. There is no evidence, by the way, that using early steroids actually definitely better faster responses, but downstream, like it's not like they have better X-ray outcomes or better clinical outcomes. We published that in Room Now last week, comparison of high dose and low dose prednisone with bridge therapy versus no bridge therapy. So,
but it's for the patients though, Jack. I mean, these patients feel better within 24 hours of being given a steroid shot or, some blast of steroids in the beginning. I mean, they know that long-term it's not going to influence, but if you're a mother and you have rheumatoid arthritis and you have to take care of this baby that's screaming and yelling at you, give me the steroids.
Yeah, one case can't drive guidelines, right? I mean,
more than one case. It's function.
No,
and
it's plenty of
quality.
cases, but what's going on? You heard what's going on in your symposia on lupus. What did Michelle Petrie and all those people say? Don't use steroids unless you've got bad news lupus, like lupus nephritis. We should be using less steroids in lupus. I mean, the evidence about steroids, and again, 1 to 4 milligrams, is there that more cardiac events, more serious infections that lead to hospitalization. There is a downside. Again, Smolin pointed out in his discussion, Eric, I think you heard that they said there was no short-term hazard, right? And that it looked like the vast majority of people got off within a year. So I don't really have a hard time with the EULAR guidelines, but I think that reliance on steroids is a loser. No matter who, whether you're Peter Merkel treating vasculitis or Joe Smolin treating rheumatoid arthritis or Michelle Petrie treating lupus, reliance on steroids is going to be a loser, and we need better ways.
It's true. Eric, what did your poll say? I just answered your poll.
And it says that one. I think that one was 80% favor the EULAR recommendations over 20% with the
because the EULAR recommendation says short duration of steroids. It didn't say over a year, it just says short duration.
Right. And what else was different about these guidelines from Dr. Smolin?
So the other big question was with how do we incorporate the oral surveillance study, the new information about the JAK inhibitors into the guidelines? Because previously they had the biologic and the targeted synthetic DMARDs pretty much on equal footing. And so they amended it a bit, and they showed all the different times that they tried to find the right wording to appease everyone on the panel. And it was hard to kind of strike the balance between knowing, these real risks that are there, but are relatively rare in the studies, and these medications that do work. And so they no longer have the biologics on equal footing as JAK inhibitors. They recommend using the biologics, and then they put in additional language saying that JAK inhibitors may be considered, but pertinent risk factors must be taken into account. So there's, again, it's the limitation of any guideline is how do we individualize a guideline that's meant for everyone, for the patient. And that's the same thing with prednisone therapy at the beginning or JAK inhibitor treatment. It's trying to take the overall guideline and put it to the patient in front of you with individual risk factors and dysfunction.
Did you see how that ruffled Artie Kavanaugh's feathers? He stood up at the end during the reading of that about, avoid JAK inhibitors in those with cardiovascular or malignancy risk. And he's like, you can't apply this as an overall blanket statement, and I agree with that. I mean, there are certain patients where you've already tried other stuff and this is the best therapy for them, this class of drugs. And just because oral surveillance showed that Xeljanz can increase that risk, it doesn't necessarily mean that the other JAKs will do it too.
So I think that they were right in stating that you need to be mindful of the risk factors. And in my group that was discussing this today, there's 3 questions. Have you had an MI? Do you have a high cardiovascular risk profile? Have you had a prior VTE? Those are the 3 questions. In the EULAR guidelines, they actually said something about looking for malignancy risk factors. That doesn't factor into this at all. That was non-inclusion criteria to be in the 1133 study. That did not pan out. It turns out that MACE and cancer had the same driving risks in this population, but that's one mistake that's in there. But otherwise, I thought that they were more liberal in how they were recommending JAK inhibitor use compared to the US, where we're sort of dominated by the FDA wording, which says use a TNF inhibitor first and then be wary of the risks. And I think that is going to lead to more stringency in the US. I think these guidelines are maybe a little more, they're very cognizant of the fact that these are low frequency events. But they want people to be mindful of them. I think it's going to generate a lot of discussion as it has here. So you guys can still hear me? I have a good connection?
Yes, you're still doing really well.
All right. You never know what's going on over here in this hotel. I want to talk to you about abstract, a poster 0242, the effect of anti-malarials on overall safety of patients taking JAK inhibitors and biologics. This was a bizarro study, a poster that comes from the group is the BioBata Brazil. It's a multi-center registry cohort in Brazil that is enrolling patients on biologics and whatnot. In this particular analysis, they looked at 1,300 patients who were in there, and they looked at those that were on anti-malarials, and that included almost 350 patients. And in the end, that the overall incidence of serious adverse events in their group was pretty high, 9.2 per 100 patient years. That's pretty high. But if you were on a background of anti-malarial therapy, right, you had a significantly lower risk of serious adverse events, total adverse events. Serious infections were significantly lower. Hepatitis and liver disease was significantly lower. And there was a slight trend towards a lower rate of dyslipidemia. Things not affected was serious cardiovascular risk, total cardiovascular risk, and hyperglycemia. So this is a surprising sort of finding. And as is usually the case at EULAR posters, the authors were not there to have a discussion with, but I thought this data was pretty interesting. And I mean, if you look at the survival of treatments, patients who are on the anti-malarials did better. There, see, I'm holding up the Kaplan-Meier plot, and the green line on top are people that are on the anti-malarial. So again, this is more evidence that anti-malarials may be much more effective than we give them credit for.
But is it also perhaps that they were pre-selecting the population who are at higher risk for cardiovascular events, serious infectious events, to receive hydroxychloroquine? Like, you know, like you say, do I give triple drug therapy to somebody who's higher risk versus biologic therapy who's higher risk? Most people would choose probably triple therapy.
Well, if it was higher risk, then, and they were on from combinations on higher risk, then you expect more events. I think it's the converse. I think maybe these patients were on hydroxychloroquine because they were perceived to have milder disease at the outset, but over time needed to get, you know, add-on therapy, which led to a targeted synthetic or a biologic. And yet maybe their profiles are different. Now, we didn't see population comparisons, those on, you know, antimalarials, those not, and maybe those on other background DMARDs. We didn't. We're gonna have to wait for the actual paper to see that. Okay. Kat, your next one?
Oh, I really thought that the abstract, I don't know what the poster number was, but it's a plenary abstract, how depression in rheumatoid arthritis can increase the risk for mortality 6 times or 6-fold. Now, I know that the presenter had gotten a lot of flack about, like, they chose antidepressant as a marker for depression, you know, the prescription of an antidepressant. But he says actually that, you know, they looked at ICD-10 codes, they looked at, you know, other markers and risk factors for depression, not just being on an antidepressant. And I think this is something that could be practice changing, because you know, we as clinicians need to be cognizant about depression in our patients, and do we screen for it? Because these patients often suffer from chronic pain. They may suffer from isolation and relationship problems. So this is definitely an eye opener, particularly when they put a number to it.
And, you know, this came up at Room Now Live in multiple sessions. We in rheumatology are not surprised by this data, and maybe we're sensitized to it because of the associations between depression and psoriatic disease, but we don't ask about depression, meaning we don't outright use depression screening tools. Most of us tend not to have the simple question, are you depressed, in your outpatient room, waiting room survey forms. And we probably should, because as Kat just said, this was sort of surprising, the data that was presented there. I actually have the poster here on my phone. I'm trying to see if there was an abstract number on it. It looks like I don't have that. So, but it was an oral presentation today, and it was a fairly well done presentation. One of the weaknesses of that study was most of their patients they identified were through the first prescription of an antidepressant. And while many of them had a history of de novo depression in the background, we know antidepressant use in RA may also be associated with pain control, right? And that wasn't I didn't hear that being discussed. Was that discussed in the Q&A session, Kat? Because I ran out of the room to go to another session.
Yeah, it was actually, because there was a gentleman who brought it up where, like, well, just because they're on duloxetine for neuropathy or something, you can't really call that person depressed. So how do you account for that? And that's when the presenter came back with, no, we looked at ICD-10 codes as well.
Oh, good. Very good. Because certainly chronic pain does add to mortality as well. Not the sixfold that they talked about. So that was interesting.
I can
Eric,
add,
what else do you have?
so I could just add that one was oral presentation 0067. So I thought that was a great talk on depression. That I thought there may be some confounders in there, but just that number and that takeaway was staggering as it was. That I thought it was interesting. I'm going to talk about another one later on in the plenary session, presentation 0071, and this is looking at the association between long-term exposure to air pollution, particularly fine particulate matter, and immune-mediated disease. This was a study coming out of Italy where they looked at fine particulate matter as measured in the hair and looked at increased risk of autoimmune disease associated with it. And you got a little bit of a geography lesson of Italy as part of the talk and where the higher air population areas are. And you can see based on that, that there is a clear higher risk of autoimmune disease, especially rheumatoid arthritis, as well as other connective tissue diseases and inflammatory bowel disease with higher air pollution. And it actually, you can track the risk that for every 10 micrograms per meter cubed, increased risk of increase in particulate matter, there is an incremental 7% risk of autoimmune disease. I don't think it's particularly surprising. We certainly know that smoking and lungs being a potential source of where autoimmune disease, particularly rheumatoid arthritis, comes from. And there's been some studies on environmental exposures in the air before, but this is just, again, just showing that the environment and what we're breathing in is playing a big risk in the development of autoimmune disease.
One of the things that was really interesting because I saw that presented as well, one of the things that was interesting, there was a question that came from the audience, and they asked whether or not air pollutant was a surrogate marker for socioeconomic status, right? Because people who have poor socioeconomic status tends to live in areas that aren't necessarily, deemed good air quality. So what do you think about that?
I think it definitely is a excellent point there. That I think it's impossible to separate out the two, but I think there likely is something. Every time we look at the lungs, I think there's a sign that there's some impact on development of autoimmune disease that I think is real. But certainly in terms of impact and risk of progression and smoking status and diet and everything that goes into socioeconomics is always going to be intertwined with each other.
Lars Klarskog, and there are others. This is not, this is one of many reports on this subject, and they all come up with the same sort of statistics and risk and at what level it imparts an increased risk. So I tend to think but going to Kat's point, there's studies showing higher rates of RA risk in inner city versus rural as well. And is that going to be socioeconomic, or is that going to be a pollutant, or is that going to be a lifestyle? There is a lot that goes into it. But the bottom line is it does fall under that environmental influence that creates the status of autoimmunity that it may very well lead to incident RA. So I want to end with two quickies that were posters, and I'm sure that Kat, you looked at this one, and that was the BRAVE 1 and BRAVE 2 studies. I think that was abstract 190. That is a baricitinib study in lupus, two different studies showing no benefit of baricitinib. And I'll remind you of I think it was Ron van Vollenhofen's phase 2 baricitinib study that looked just great. But as usual, phase 2 always looks great. Phase 3 is where everything goes to die. Do you think baricitinib is dead in lupus, Kathryn?
No. I don't think nothing is dead in lupus. I think they didn't study either the right population or, their inclusion, exclusion criteria. There's just so many different aspects to a lupus study that I just don't think it's dead yet, and I wouldn't give up. And the reason why I say that is I have used baricitinib off-label in my lupus patients, and they actually do well. But that's just my N of like a handful, okay? But I think that we shouldn't just like scratch it off the list.
No, but I'm already hearing talks about, well, maybe we didn't include the right patients or use the right endpoint. The SRI-4, I think, was the endpoint. But this is what led to the SRI-4 being formulated to allow for a better endpoint and better outcome with belimumab. So you can't keep renegotiating your endpoint measures in lupus. The mistake made here is going for an overall lupus indication as opposed to going after organ-specific lupus, where there's less doubt about what your endpoint is and what you're actually measuring and whether they really get better or not. Basing it on SLEDI and SRI-4 or the LL-DAS or any of these newer ones and going for a global indication in lupus when lupus is either 5 or 49 different diseases is, I think, a gigantic mistake.
Right. And I would clarify that where I've used baricitinib in my lupus patients off-label, it has been in patients with inflammatory arthritis and skin disease. So, but yeah, you're absolutely right. It's kind of hard to interpret, but I know that I was a little bit disappointed with those results.
So my last comment was going to be on poster number 200, which was post mRNA vaccine flares of autoimmune disease. And I don't know if you saw this, but I thought it was interesting in that it basically looked at a cohort of, I think, almost 8,000 patients, or trying to read this, it looks like 4,600 patients. And they documented 542 flares for a flare rate. And these are patients with a rheumatic and inflammatory arthritis. The flare rate was 11.4%. Most of them were mild, but 14% were severe. Most of these occurred, the median time to flare was actually 40 days. And most of the flares did, in fact, resolve. And I guess this is different than de novo new rheumatic manifestations that happen as a result of an mRNA COVID-19 vaccination. Does this jive with what you're seeing in your clinic?
Eric, you want to answer that?
It does for me. I think we do see that that there are flares with getting a COVID vaccination. I think the main takeaway is that it is rare, but I think that it is mild, that we don't see these severe flares, but it's not a rare finding. And especially if we're holding medications around vaccination, we're giving them something to stimulate their immune system. We do see that patients do often come back and say that their disease activity is mildly increased, usually not to the point that we need to change their medications or even give them steroids, but it is something that's commonly seen. I think it's been minimized because, again, it comes back to the risk benefits, and the benefits are usually there, but it is something that patients do ask about, and often we've minimized the fact that they are sometimes experiencing a change in their symptoms.
I think we also need to have a study looking at the percentage of patients who flare their rheumatic diseases after COVID-19 infection.
Mm-hmm.
Because I have a feeling that, it may not be 11% that flares, but it's going to be 25% that flare. Because I've had quite a few patients who actually, their rheumatic disease end up getting a whole lot worse after they've been infected. So we really need a denominator to this. And I think that just spouting out numbers like that is just kind of fearful without comparison.
Yeah, I think that would be a great idea, although the number of flares from infection are going to be less than flares from vaccine, just based on our observations. But I think why it has some validity here is the story of Still's disease and vaccination and infection. There are a lot of cases of new onset, what looks like Still's disease in people receiving the COVID-19 vaccines, and usually it's the mRNA vaccines, but also new onset of Still's disease with infection as well. And I think that that just says this, it's either the spike protein or other aspects of the bug or the vaccine that are capable of inciting an innate immune response in certain people, but not most. And that's where you're getting these rheumatic manifestations. That's where you're getting the flares of existing autoimmune disease. That's where you're getting even these reports of Still's-like disease. That's my take on this so far.
Yeah.
Okay. All right, folks, thanks very much for taking the time to give us a recap. Hope you enjoy the rest of the meeting. Those of you out there listening, tune in for our recaps every day at the same time. We're going to live stream it on Twitter, Facebook, LinkedIn, and our YouTube channel. And for those others who don't want to do that, they can actually watch it on the website and in the email.
Jack,
See you
guess
tomorrow.
what? Guess what, Jack?
But
I might have to come see you because my maid quit and I have a lot of micropollutants in my house.
you're going to come see me in Copenhagen?
Oh, I only wish. No, when you get back, my joints are hurting. And part of that's house cleaning myself.
I'm not coming back to Texas then. You can forget about that. Call Eric, give her your phone number. Let's do it that way. All right.